industry conferences is that clients are demanding lower and lower rates. And that's due to a few things, due to a number of factors, but there's 3 factors we're hearing over and over again. Number one, we're hearing that revenue cycle is becoming increasingly commoditized. And as owners or directors or managers, practice professionals tend to think that billing's easy. Well, we have the EMR and it sends the charges to the PM and the claims go out and you get paid and you collect your cut, and that's how easy revenue cycle management is. So the perception of the work has been commoditized. But at some level, because of offshore vendors, primarily in the Philippines and in India, being able to get at labor costs that are so much less than at the U.S., they are really able to offer a greater level of competition in the market. And to remain competitive, billing rates have dropped down in the 3s and the 2s, which is insane. Because, sort of back in my Boston days, we were doing, premium surgical services in the 7 to 10% range. So international competition has driven down rates, and more billing companies are outsourcing major parts of their business process to offshore vendors and utilizing those vendors to their advantage. The EMR and the PM vendors have also gotten into the game here. There was a lot of money given out to practices to invest in electronic medical records and PMs, and the market was saturated. Especially our experience in the community health space, where there was federal money given in the form of grants to purchase technology. But at some point, the practice management vendors are starting to recognize, or have recognized, that the market is so saturated that they've started to dip into the revenue cycle services world, where they're offering free licenses and free access to their systems for people who are willing to take on their revenue cycle services. And that can be very, very difficult to compete with because you're already at some level working to either bring in outside services as a consultant or bring in outside technology as a technology vendor, or as a revenue cycle firm, you may be looking to outsource their entire billing operation. And so it can be very difficult to tease people away from that when they're getting competition from their PM vendor. And then we're noticing that there are fewer and fewer smaller billing companies, smaller local regional billing companies, which the large regional companies will refer to as, mom and pop shops, but that's not really what they are. They're really specialty billing practices that have grown up around being the best in their area, the best in a particular surgical specialty, whatever it might be. They're very niched, and they were very good at what they're doing. But because of some of the competition from the left side of the screen here, and these very glossy EMRs, which especially hospitals love throwing money at, it can be very, very difficult to compete with those forces. So if we talk about automation and your margin, we went out and we talked to a number of CFOs out there, and we got back some benchmarks for what margins should you be really looking at. These are really broad strokes here. We understand we didn't poll 50% of the market, but the best performers that we spoke to have margins up in the 30s and 40s. Getting up in the 40s was especially for a service industry is extremely high margin. On the other side of that, billing companies, RCM firms, service companies with margins less than 20%, down towards 15% is where red flags really, really need to start to go up. So the way over the the trend over the last decade or so at least, has been that companies are using software technology and automation and offshore business process operations, business process outsourcing to reduce their costs. And so those who have the highest margins are some combination of highly automated, and they may have a combination of that and a largely offshore presence. Either that or they're highly automated and doing that work extremely well internally with very little to no offshore. But either way, they've had to take a lot of the human element out of it, because for most of you, your highest expense is going to be payroll. In a service industry, that's going to be the highest expense. And the only way to grow without growing your payroll is to take out the manual work. So we'll talk about that a little bit. So again, those folks, my experience when I started at PMG was they were doing a lot of work on spreadsheets, capturing denials, capturing AR, passing exception claims back and forth to their clients about what they could and couldn't, what work they could and could not get done. And there were, across 40 clients, there were thousands of spreadsheets in terms of cash logs, rules logs, all of those things being kept in spreadsheets or paper reports was very, very expensive. So for them to grow to who they wanted to be, we had to develop some of these software technologies. So there are some real benefits to going offshore. And by the way, I'm not proposing that you keep your business offshore or in-house. I'm not a proponent or opponent here. That's not our stance. We're just trying to identify some of the places where there are values in one direction or the other. So offshore work tends to be very production focused. If you have a large offshore shop working for you and you've outsourced charge entry or payment posting or even some of your claims resolution activities, you want to keep them moving with high production, like the billing 101 stuff, the stuff that they can move through really, really quickly. You're going to get the most value out of high production activities from an offshore vendor. That's not to say they can't do the more complex stuff, the coding, the analytics. They're probably very, very adept at technology, but the best value you will get is to keep them moving in more of a production sense. So they're just churning through the stuff that it's too expensive to pay someone onshore to do. Most offshore vendors, many of them started as technology companies. So they are measuring their teams with team performance tools and automation. So they have workflow systems, and they know how much time each one of their team members spent on a particular claim. And they can, internally, they manage that data very strictly because, again, in a production environment, those data points matter. Their costs may be transaction focused, not typically the offshore partners, BPO partners that I've worked with and spoken with. They're open to different ways of billing for their services, but many times it's costs you X cents to post a payment or X cents to post a charge. And so sometimes the incentive there is just to get the transactions, not to say that they're manufacturing them, but the incentive is not necessarily to do the optimal claims resolution up front. And they're dependent on strong rule management. My wife is an example. Their billing department, she works in an orthopedic supply company. Their billing department was sent to an offshore provider. She goes to India twice a year to train the staff. And she'll spend 2 weeks just constantly training and creating rules. And she has to monitor those rules assiduously. She constantly has to make sure that, number one, the rules, because there can be a culture divide, that the rules are written in such a way that everybody understands exactly what they mean, but also so that they understand that those rules might change in time, because the payers love to keep the target moving. So onshore, there's typically, when you outsource to offshore, you're not going to outsource everything. You're going to need staff onshore, sort of from the bottom of the top. You're going to want folks, typically practices want to be interfacing with somebody onshore in your office. Many times they'll demand that patient interfacing, patient calls come to an onshore call center. So some clients can be very demanding. Some clients can be very demanding that they won't let you even use offshore. I think there are some state regulations out there that at some level prohibit any data going, quote unquote, offshore. Additionally, your onshore staff may not be tied into offshore performance management systems. So all of the automation and performance management systems available to the teams in India or in the Philippines or wherever you're doing your work, or wherever that work's being done for you, your team doesn't typically have access to those systems But you need that team, and they're typically required for more complex claim scenarios. They may be your account managers or your top claims resolution folks. But again, to get the most out of it, you don't want your offshore team spinning their wheels on complex claim situations that cause huge amounts of appeals and constant follow-up with the payer. A lot of that is typically managed onshore. So what that means is if you have a significant portion of your business at an offshore partner, in order to bring your costs down, in order to improve your margin to stay competitive, you're going to have to automate things for the folks on the right, which is the folks that are stateside. And they're more expensive, and that's just the truth of outsourcing as a whole. So just a couple statistics about data. Seagate, Seagate makes disk drives for most of the world, and they did a study on what was happening in the market, where they were seeing market trends, and they found that in that study that healthcare data is expected to grow 13% faster than other industries. And what they're defining as hypercritical data, which was primarily clinical data, is expected to possibly, on average, double every other year. And we've seen it, and we're seeing data, and I'm going to talk about it, machine learning and AI, and those words are getting thrown out in every marketing presentation. I'm not sure everybody totally understands what they're always selling when they're selling those things, but data is what everybody's pining for. And so the articles that I read on, when I'm out reading online or on LinkedIn are really talking about using data, artificial intelligence, machine learning in the clinical setting. But I'm not reading a lot about where data, AI, and machine learning are being used in the revenue cycle setting. And I think that's because, in my experience, the revenue cycle, there's this perception that they're in the basement and they're working your claims and it's really easy, and they're all down there with their green visors on, and we'll worry about them when we get to them. But the clinical operations side and the clinical outcome side is where investment dollars need to be spent. If you're running a billing company or a revenue cycle management firm, that's not farther from the truth. So the whole revenue cycle. And from our perspective, the revenue cycle includes the front end. I mean, from everybody's perspective, it includes the front end. It includes the providers. It includes the front desk, the contracting teams. It includes credentialing teams. All of those folks on each side, both at the client and in our business, benefit from data. As a billing vendor, there are still some transparency questions out there in the market. There are still folks who, if you ask them what they're most frustrated with their revenue cycle firm, is that they don't know what's going on. My billing company won't tell me what's happening. I keep looking online and I find one claim that didn't get worked, and all of a sudden all the claims aren't getting worked. So transparency is a big deal in the revenue cycle firm, and having in revenue cycle market, and having a greater access, or giving your clients greater access to transparency to what you're doing month to month, does two things. One, it allows you to brag and remind them in 3 years, when you've taken their days in AR from 120 days to 40 or 30 days, and they're at 30 days and they've been there for a couple of years, and they forget where they were before they started. So data transparency and analytics can continue to show them those things. But it can also get everybody on board and eliminate wasting time, and automating communication, and giving feedback to each side of sort of this triangle on the right of the billing team, the front desk, and the providers, and all the people in between. The most successful revenue cycle clients are the partners, the people who come to you and say, tell me what I'm doing wrong, tell me what I can get better at. The ones that are not as successful are the ones that are not willing to accept the responsibility for the things that they can improve. They're not willing to accept the fact that there's a significant amount of work that's created in the billing department that generates both at the front desk, providers, credentialing, contracting areas. And a lot of times they're unwilling or unable to accept those things because they don't have the actionable data to know. So as we talk about data and automation, I mean, data is really the foundation of automation, and we start to think about all of the different parts of revenue cycle, from data entry, claims management, denial analysis and capture, client month-end reporting. There's just so many places we could focus. And from our perspective at Revenue Health, we focused on a few, and we made a decision back when we were billers and said, we need to fix these things first, and then everything else can sort of fall in line behind it. So there's probably some words on screen there that are maybe more important to you. Maybe it's eligibility verification. Maybe it's pre-authorizations. Those pre-auths might be the bane of your day. So what are some of the technology buzzwords? What are people talking about? You might hear of RPO or RPA, which stands for Robotic Process Information. And RPA uses software to automate things that humans do in a repeated fashion. So RPA may be things like data lifting, so going into an EMR and picking words out of an EMR entry. It might be optical, OCR, where you lift data, doing data lift from PDFs. We do some of that. I'll talk about that a little bit. It could be screen scraping. Some technology vendors have built systems that will log in and pull data out of Medicaid's website so you can check eligibility. But they're also using robotic process automation to do things such as claim status, eligibility inquiry, and data entry. And if you're using, especially if you're using a large offshore, especially out of India, a lot of them really employ and really lean on those technologies, and there's a great benefit to them using them. There's also automation in terms of workflow management. And so workflow management technology produces software that automates the analysis, prioritization, and distribution of work. Now, some workflow management tools, and I'm a little jaded here, especially some of those that are built by some of the large EMR PM companies, take denials and work and appeals and they drop them into a queue. And you start at the top of the queue and you never get to the bottom of the queue. And if you ask your coworker, hey, you were working on a queue last week, how many of them got work and how many of them got paid? They can't tell you. So really, automation-focused workflow management tools not only automate the analysis, but they have smart rules engines that automate the prioritization and also the tracking of everything so things don't get lost. From there, we get into artificial intelligence and machine learning, and you've probably attended an AI or a machine learning webinar at some point over the last few years. It's not brand new, but AI enables technology to mimic or perform human tasks. You may have interacted with AI in an automated call center, or you get a robocaller at your home trying to sell you something. And whatever you say, the artificial intelligence responds. I get someone who wants me to make a donation, and I say, are you a robot? And it comes back with, no, I'm a real person, and it's definitely a robot. So a subset of AI is machine learning. And machine learning is software. It's AI that gives computers, technology, the ability to learn without being programmed to do so. So what machine learning does is it listens to signals in data, clusters of data, and it makes decisions based on what it's seeing in the data. And you don't have to tell it how to make those decisions. It learns the more data that you give it, the more controls you program, the more signals you tell it to listen to, whether those signals are provider, insurance, state-based, procedure-based, whatever those signals might be, a machine learning application, a machine learning robot will take those signals in and can start giving you some insights you weren't looking for to begin with or wouldn't have thought to look at. And that takes us to analytics versus business intelligence. And there's a lot of different definitions for analytics versus business intelligence. Analytics really, again, from our perspective, focuses on dashboarding, comparative data points, key metrics, reporting, trending. Those things are all analytics. It doesn't become real business intelligence until it starts to include context and direction needed for decision making. When you have analytics that's put together and tells you where you were last year, where are you this year, and where you might want to be next year, that's business intelligence. And so combined, there's a lot of opportunities in the revenue cycle to apply these different technologies, and there are a ton of companies out there that are doing work like this, one of which is Revenue Health. So as you start to evaluate automation, there's some key questions that you need to ask. Number one, do you have access to the client system? So if you're doing, billing and revenue cycle for a hospital or practice, many hospitals may require that you remote into their system and use their network. So automation may be difficult to do if you can't even get to the practice's system or the existing data. Do you have access to the data? There are some, I've met some revenue cycle firms who are highly automated, and they are the ones who are hosting the practice management system, and so they have access to all the underlying databases. And when you have access to those databases and that data, you can really do a lot of cool stuff. But if you don't, you can really have some barriers go up in front of you in terms of automation. So do you have the expertise internally, or do you need to lean on consulting? Do you have a data scientist in the building? Is a data scientist even a real thing? And what is it? Do you need to pull people in who can help you design systems, not just technology systems, but process systems so that you can get at the data? Do you build it? Do you buy it? And then maybe these last questions are the most important. What can you implement now? We're, as a company, Revenue Health, constantly trying to decide, how are we going to budget things? We have X amount for X projects, but what are we doing tomorrow? We have a 3-year plan, but what are we going to do tomorrow to keep moving forward? And so if you're back in that lower left quadrant of practices that are not automated, that do not have enough of their BPO offshore to keep their costs way down, where are the greatest, quickest opportunities? And then what's the cost of implementing? Not just the financial cost, but the burden onto your staff. How much IT infrastructure do you need? How much system management do you need? Do you have people who can manage this software after, the folks parachute in, leave their software and go? And then finally, can you increase your margin, and can you grow without adding more staff based on this software? The reality is you're not going to automate everything. You're not going to cut out 100% of payment posting. Even in a given check, there's going to be some payments you can't post. The software can't automatically import. So you may need a human to do that, right? So what can you automate so that maybe you're not eliminating staff? Nobody really wants to eliminate staff. I think probably the goal is, can you grow in a market with rates that are so low without adding more staff? And if you can, that's really one of the optimal scenarios. So talk a little bit about addressing operations automation and how we look at it at Revenue Health. Obviously, we're conducting this webinar, so this is going to be sort of our perspective, and we appreciate you listening. We'll give you a very high level, and we're going to come back in some future programs to talk about specific areas in more detail. So we talked a bit about a multifaceted approach, and our theory is that through some portion of remote process automation and machine learning, which may be getting rid of paper through EOB to 835 conversion, or some machine learning projects that we're doing where we're running through millions of claims to do predictive denial analysis and claim denial prevention. So one of our goals in our development cycle over the next year or so is to be able to go back to our clients and say, this claim's going to be denied because of these reasons. So they can go back and check the medical record and check the practice management system. So maybe it's just a real denial and they can't stop it. But let's tell them what might happen through some of those technologies. Today we're going to be talking about AR analysis and management, and we'll talk about how to identify trends, or how systems identify trends, prioritize work, how you create a safety net around your AR analysis. Guessing all my little circles are going to be off here. Look at that. So not quite close. So we're also going to talk about denial source identification. So there's this two-pronged approach here of making sure that your client's AR is singing. That every bit of AR that gets into, every balance that gets into that AR, both debit and credit balances are getting worked. They're not getting lost. They're getting prioritized. But then going through the process of engaging your clients to slow down or stop the influx of new AR. Because the best case scenario for us, the best denial for us as revenue cycle professionals is a denial that doesn't happen, right? And so putting systems in place that help clients get to that point doesn't take you out of the equation. It makes you invaluable. And then let's see if my last circle lines up here. Oh, almost, okay. The last piece of this is taking all of the data out of the AR analysis that we do and the denial source identification that we do and coupling all that into business intelligence that allows us to measure staff productivity, resolution rates, evaluates client performance. And I don't mean who's got the best days in AR. I mean, you need to measure those things, but which client's costing you the most money to run? That's critical to know. I have clients that are on GE, I have clients that are on Epic, and I have clients that are on my in-house billing system. Which of those are giving me the best bang for my buck? Where's my margin the most optimal? Again, we'll come back in later months in later presentations and talk more about sort of the evolution of remote process and machine learning. Right now, we're going to focus on the things that we decided to focus on, which is getting the AR singing and slowing down the flow, sort of stop the bleeding with new AR. So when we talk about intelligent AR analysis and management, when we designed systems, we had some core sort of solutions, core values that we wanted to put in place. Number one, we wanted to isolate only actionable work. So we didn't want our team working on claims that were too young. We didn't want our team working on claims that were too old. If you're saying, well, what claims are too old? Well, if the payer has closed their books and they're not going to pay those claims, you might be working claims that are too old. Statutorily non-covered services, things that are never going to get covered, that might just be sitting on the AR, somebody didn't work. Open denial reasons. You may have a particular payer for a client in a state, and that state, if it's Illinois, they run out of money halfway through the year and Medicaid just stops paying for claims. Or you have a client who didn't submit particular report to Medicare, so now they're not getting paid for their claims and you can't collect. So how do you capture those and isolate them? So I'll show you an example of that in a moment. And then intelligent AR analysis that's rules-based. So can I write rules that break up my AR and prioritize it based on my payers, check write schedules, right? Well, if I just worked a claim 2 days ago and the payer only writes checks every 2 weeks, it doesn't make any sense for me to look at it in 5 days. Do I have filing limits that are approaching? I don't want to look at something on the 89th day of a 90-day filing limit. I want to look at something on the 58th day. So if I work it today, do I have a system, and our systems go in and evaluate those claims and say, hey, you looked at this. In the old days, you would have put this in your tickler file for next month. We'll open it up. This one's automatic. You need to look at these. And does it identify critical claims? Does it identify high-dollar claims? Does it group claims together so that you have one person every day, they log in and they see the most important claims you need them to work every day? And then we implemented workflow actions. So we implemented a workflow that would automate the distribution, again, prioritize, do critical claims prioritization, but also staff production monitoring and resolution rates. Because you can reprocess and appeal claims all day long, but if they're not getting paid, you're not having success. So the workflow system, number one, makes sure that nothing falls off the radar. But also, number two, it tells you who's being the most successful at collecting AR and what actions are they taking. So now the analysis becomes the automated analysis of the work people are doing and the work that's successful. So you can go out and replicate that, and if you do have offshore staff, you can come back and tell them, you touched all these claims, these are the ones that you got paid, here's what you did. So go train your staff so they can be even more efficient for you, or your internal staff as well. And then alerting, and it really should say alerting and analytics, because all of these things dovetail into analytics. So are there growing pockets of AR? You don't want to know that AR is over 90 days. You don't want to know that your AR over 90 days for a client is growing. You want to know that your AR over 60 days is growing. And you need to know that it's pre-diagnosis, it's preventive health for your accounts receivable. So are there claims that are just getting no activity whatsoever? Just, maybe they're rejected claims. They're unworked rejected claims. You thought somebody worked them, but they didn't. Maybe there was a payment that didn't get posted. You have the remittance file, it got lost, somebody just didn't get the payment. So now you've got people spinning their wheels on AR that's not even really AR, they're paid claims. How do you age and manage your self-pay? If you're doing that in-house, or if you have a vendor, beyond 3 dunning letters and a statement, collection statement, how are you managing your self-pay? What times, if you're calling on self-pay calls, what times work? Can you go back and look at the collections activities on self-pay, and then what new denial trends are causing the AR to swell? So again, you can go back to the front end and say, when you're at 30 to 60 days, hey, you're doing X and Y, looks like things have changed, you need to retrain your staff. So in terms of, this is an example of a work list that we built for a client, and on the left, they were having a huge problem with a Medicaid managed care organization, and there are, there's got to be 10,000 claims on the left, and these were all just interdispersed with all of their claims. And so what we did was we wrote very, very specific rules to isolate these claims for them and to put them in one place for them on the left. So on the right, they had each of their staff intelligently working very specific claims. They're calling out filing limit denials. So the way that they were organizing their AR was no longer just, I get a report, I start at the top of the report, I work to the bottom of the report, and I don't know what I did. But they were able to isolate things they couldn't work, put them in a place where they could store them so that when they actually filed the appeal with the payer and that payer paid all those claims, all of these claims automatically just fell out of these lists because the system was listening to the AR. So that's the value of isolating actionable claims and intelligent rules for your team. You want your team working these claims that they can actually get paid, and if there's a project out there, you don't want to lose those claims. So the other side of the coin here is to eliminate inbound AR, and the way you're going to do that is with denial source identification. There's a number of ways to do it. One of the keys is stop claims from getting denied in the first place. And so there's really a 5-step process here that our system delivers, a very top-down approach. Number 1, identify sources at the client. Give clients dashboards. Give clients dashboards so they can see detailed data on what facility, location, department. Do I have to go train my staff at the Main Street location or at the West Side location? Clients are pining for that. They will love you for it if you're not already doing it. And if you're doing it, and you're doing it in PowerPoint presentations or reports, it's costing you a lot of time and money to put those reports together. So all of this is about automating those activities. Again, isolate actionable claims. Don't go out to clients with things they can't fix. Go out there with the claim numbers on the claims that denied last week and say, hey, look, here's your list. These are all registration denials. These are all dental denials or radiology, whatever they might be. Give them the actionable data that they can get to. Give them the claim detail. And then focus. Make it an organizational partnership where the 2 organizations, you and your clients, get together and say, we're going to identify the top 2 to 3 denials, the top 2 to 3 denial sources, which, by the way, through at least the analysis that we've done and over my years, their top 2 or 3 denial sources are probably 20 to 30% of all their denials. So maybe go work one. Pick one. Maybe you've got some credentialing issue and go bring everybody at the practice in the door. Resolve that issue. Engage the front desk, the providers, the billing team. If you're working with a hospital, there's probably a large contracting team you have to work with. Bring everybody to the table, and I know as a working professional, when people give me 11 things to do, I don't want to do any of them. But when they give me just the first thing to do, I can concentrate and I can focus. So focus on that work, bring everybody in to a very focused approach of resolving it, and then monitor it. Eliminate those denials, but then every month create a process where your clients are going in and making sure those problems haven't come back. And again, you're talking about registration, eligibility, credentialing, talking about non-covered services, all of these things that are out of your control. If you start to give the practice the ability to know what they're doing wrong and train their teams, you become an integral part of their practice. And so when the performance is great in a couple of years, they won't be able to live without you. So here's some examples of just sort of identifying inbound AR. This particular practice had a denial rate up in the 25s, which is high. And unfortunately, it's not uncommon, but that's a very high denial rate. MGMA says it should be under like 6 or 8%, and best performers are probably 2 to 4%. But for the practice, for the revenue cycle firm, it was critical for them to drive that denial rate down. And they identified one of their top denials as registration denials. So what we built for them was a dashboard that focuses on just the top denials and then the questions, answering the questions around eliminating that inbound AR. So automating this work, not having to take the time to find out where are the denials coming from. This little blur on the left is the facility. So what denials are happening at what facility and what payer over time are they getting better? And this practice focused on these denials, and eventually that particular segment of denial, which is a front-end denial, which they can control, and they were very, very proud of the fact that they had driven this down. And so if they were just looked at this at the second half of the year without a comprehensive analytics system, they can't see where they were to where they are now. And these types of things need to be applied internally to the billing operation. So again, a really, really great success story of a billing company who gave a practice the data they needed to make a problem go away, and now the billing company is touching, half as many denials, at least for this reason. And that traction impacts operations. So the volume of inbound new denied claims showing up on their work list is going down. And that's what they need. That's what they needed to get caught up. So we've talked about automating workflow management, and we're happy to talk to you more about the product details around how those things work. But again, those first two focuses are get the AR in a place where it's singing, analyze what's on the AR, what are your top opportunities, what are the balances that are over $1,000, for example. If you're in some sort of primary health practice and you're doing a high volume of claims, some are very high dollar compared to the others, can you isolate all those? Can you track all that work getting done? And then can you keep the flow of new AR from coming in the door? The second side of this particular automation effort is automating the analytics and the business intelligence. So we've talked about this a little bit, and I'm going to sort of start from the top left, and I'll go clockwise here in this cycle. But number one, can you automate client performance indicators? And I'm not just talking about payments, net collection rate, and days in AR. I have some other indicators which we're going to talk about. When you get data, you can start to create new indicators, which are kind of fun if you're a data nerd, which I am. But also team for performance analysis. So when your team gets work, how do they do? Who are your most productive personnel? Who are the most effective personnel? Who are your highest performing teams? And what are the most lucrative actions? When your people take actions on claims, both onshore and offshore, which ones are getting claims paid? And then as you start to improve your team performance, which will improve your client performance, what opportunities do you have to evaluate company and client comparative business intelligence? So can you compare, again, as I said earlier, can you compare your margin across your client base by practice management system? If you're on one practice management system, you're in multiple states, is it more profitable should you be driving sales to California instead of Arizona versus Texas? Are you focused on multiple specialties? If you're not focused just on one, if you do orthopedics, psych, primary health, and OB, is one of those the things you should be driving your sales towards? And are there business models that are working better than others? For example, do you have more than one offshore partner? One strategy that has been employed and been recommended for people who want to offshore is to get 2 offshore partners so that they'll compete with each other. So is one of them performing better than the other? And so again, now you're starting to make decisions about how the business grows, where you're making the most money, where you're getting the most margin inside the business as a whole. And then in addition to that, down the bottom left, with the data through automated AR data collection analysis, automated denial data collection analysis, you can start to get actuals on client performance. I mean, how many times if you do this that you go out to speak to a prospective new client, they say they're doing $10 million in cash, and you bring them on board and they're doing 5. They say they only have X doctors and they have, they only 10% is self-pay and they're, 30% self-pay. But also during the sales process, can you identify pain and opportunities? And I'll show you that in a second. And can you demonstrate expertise? When you walk into a practice and you can get their data, you can do it for free, pull their data in, come back to them and already start telling them where they can improve. Your expertise is on stage, and that's really what people buy when they buy Revenue Cycle. They do see flashy technology, but they want to hear people who speak their language and who are experts in whatever they do. And it's probable that if they're orthopedists or neurosurgeons, they want people who know about neurosurgery. So if you can demonstrate that expertise, or if they're in New York, they want someone who understands APG payment models or whatever payment models are going on in that state. So there's the opportunity to offer some new perspectives. So again, traditional KPIs such as cash collections, days in AR, those are never going away. Cash is the ruler of it all, right? But there's some new metrics that you can get access to, such as blended encounter rate, average payment per paid encounter, denial rate. And so if we take a look at that, here's some data that we pulled out from a client's client where their client was doing, in this 6-month period, they had done about 18,000 unique encounters and collected just over $2 million. So on average, they were collecting about $115 per visit, or you could call that a blended encounter rate, just the encounter rate that they're getting paid for all of their services across an entire time span. Even if some of them are office, some of them are surgical, doesn't matter. You throw them all together, on average, what are they getting paid? And then you isolate that just to the paid claims. So go into their AR, go into their remittance data, and identify when you get paid, you're getting paid $140 on average when you get paid. So across the practice, and this is a little backwards, across the practice, if they're looking at 36,000 annual claims and a blended encounter rate variance of $25 between $140 and $115, for them that's an additional $1 million. Now you multiply that, that gets exponential across your clients to the opportunity downline to your clients, and that becomes additional revenue to you. At the same time, this particular practice had a 27% denial rate. It's actually not the same practice as the other one. So it's, again, unfortunately, these high denial rates are too frequent. And so to you, maybe you know this number, but the MGMA says, and they said about 3 or 4 years ago, that the average was about $25 per claim to resolve a denied claim. In reality, it's probably the first time you touch the form, probably more like $10. And it gets into the 20-25s into the second or third time you touch it, whereas if it gets into AR over 90 days, it's probably more like $30 per claim. Again, depending on your model, depending on who's doing that work for you. But if we just assume this math for argument's sake, and you're paying $25 per claim, and you're touching 9,000 claims in a year, that's $247,000 that you're spending on human resources. So how many people does that equal over just this one practice? Probably not linear. You probably have some stars who could crack through these denials and, you wouldn't even notice it. But again, how many people are you having to keep on staff, on shore, because the denial rate is too high? And how much money is not going into your business because there's claims sitting out there getting denied that are either not getting worked on the AR or they're getting denied in the first place? It's better for you, for the client, to be collecting $140 across their claims. So evaluating your clients, there's different ways that you can evaluate your clients. The blended encounter rate, some of those different metrics, touch rate, on average, how many times are you touching claims? Those are some other metrics that you can get out of data that you're not going to get out of traditional clearinghouse data or practice management data. So the other places you need to be looking at evaluating are your billing team. So your billing team, can you understand your biller or your client resolution rates? Can you measure your client resolution rates against each other? I'll show you that in a moment. Can you audit and evaluate your billers? The onshore billers, can you audit and evaluate your offshore billers? Again, do you know which actions are producing payments? And are your team members getting data on what they're doing right? John Gordon wrote a book called The Energy Bus, and like the first 5 words of the intro or something like, start catching people doing things right. And we've met billers where they were so excited to learn, oh, I resolved 100 claims and 90 of them got paid. I did that. And that really, sharing successful activities, that has a huge positive impact on getting people to start doing the things right. So when we take a look at resolution rates, for example, so this report here shows the volume of claims that a biller actually worked in a time period, and then what happened to those claims. Were they resolved? Were they adjusted? Do I have 2 billers working the same volume of claims, and are some of them just adjusting more? Or do I have one biller who's handling thousands of claims and getting thousands of them paid, right? So in our system, shameless plug, all of this is interactive data, and you can report it by user, payer, client, state, all of those peer groups that we call them, they're in there. So you start to compare month over month. What % of the stuff that I had in January is resolved? And when do I think it should be resolved? So this type of comparison doesn't have to be just at the biller level. It can be done at the company level. If you have 2 offshore vendors, if you have teams, you start putting them, lining them up like this, and you can start to see, wow, this person, super high productivity, pretty darn high resolution rates. It's one of the highest resolution rates that I've got. I need to know why this person is doing so well. I also need to go and understand why this person has adjusted off so many more claims than this person. So there's 2 sides of that coin. So in summary, we're getting towards, I'm in outside of Providence, so it's about almost 2:30 my time. So be respectful of everybody's time. Market trends are driving rates down. So the only way to respond to that is to reduce costs. You can reduce costs by offshoring more work if you're not offshoring it already, or you can reduce costs with automation. And which of those solutions is right for you is up to you. But if you are going to focus on automation, you need to focus on operational efficiency. You need to be able to do more with less. You need to be able to take on more business, more encounters, more surgeries, you know, whatever it might be, with either the same amount of people or maybe even less people. You need to drive clients to do the things that help you give them the best results you can give them. You can't just keep everything internally. You have to get the clients to buy in. You have to give them the data. And you need to start to automate company business intelligence. How is the company performing? How do my clients perform against one another? So that you can start to niche down and really understand what you're the best in the world at doing and go out and selling those things and really taking over the market. So again, for us at Revenue Health, you know, we focus on business intelligence, denial management automation, and AR management automation. Those are the things that we're focused on. We can do a lot of other things. We'll be talking about them more in future webinars. But I wanted to say thank you to everybody for listening. I wanted to open it up for questions now. I will stay on the line as long as people want to ask questions. So if you have questions, please feel free to ask them. And at that point, Amanda, I will hand it over to you and let me know if you've got any questions from the attendees.
Thank you, Jeffrey. So everyone, we will go ahead and open up the chat if anybody has any questions, and it does look like we have a couple that have come in so far. So Jeff, first question, what do you see as the single greatest barrier to automation?
That's a good question. You know, it's tough to narrow it down to just one, but if I had to say the most difficult thing to get over, in my experience, has been client information technology. So, for example, I've been involved with building analytics systems for one Boston-based hospital, and the hospital IT department and the practice management system was so closed that even though the CEO and CFO had made a technology decision, it made it almost impossible to get to the data. So one of the most difficult things to do is to get over a closed-ended practice management system or practice IT department who, you know, they're so risk averse and they're so concerned about security Not that they shouldn't be, because they should be, but that they're not open to any new business-enhancing technology. So I think that's the single most. There's a lot of others, but that's probably one of the most difficult. Thanks for the question.
Great. And we have one more. So what if my clients are using different PMs? Can your system handle that?
Yeah, we can. We actually built, when we built the system, we were on maybe 6 to 10 practice management systems, so Allscripts, GE, NextGen, Greenway. I think back then, trying to think of some of the other practice management systems. And this system that we developed lives sort of in the middle, in the data sort of cloud here in between the clearinghouse, the payers, and the practice management system. So we do pull some data out of the systems, but we don't have to interface. We can just pull reports. And we've written some intelligent software that will take reports and pick them apart and pull the data into our system. And also remittance data, AR data, all of those things we can do, and we do without a single interface set up with the practice management system. Now, if we have a client who has a strong tie to the hospital or a strong tie to their practice and they can do those interfaces, we absolutely like to go down those roads and tie together. But yeah, we built the systems because one of the problems that we were having was getting access to those particular systems. So looks like Amanda lost her connection, so she's sending me a chat of other questions here. The question is, can you tell me where I can get RCM benchmarks? Yeah, that's a good question. There's a number of different places to get RCM benchmarks. An okay one, and with all due respect, MGMA, they collect data, and just like any data collection effort, they're depending on who's responded and how honest the respondents were. So MGMA, and especially your regional MGMA, if you're a regional billing company, that can be one place that you can, or yeah, if you're a regional billing company, your regional, you know, like for us, it's the New England MGMA, that could be a place where you can go to get some of that information. Also, HPMA has a lot of great community functionality, so reaching out to them as well can be a good source. I hope that answered the question. Other questions, Amanda? Again, she's having to talk to me in chat. All right, well, it's just about 2:30. I don't see any other questions. You can find us online at revenuehealthsystems.com or on LinkedIn. We have a Twitter handle, @RevenueHealth. So, you know, we're constantly posting new blogs to our website, a lot of content to LinkedIn. We'd love to have a conversation about this. If you want to send us an email, if you'd like a copy of the recording, we'll be posting that up to YouTube, and we can send you a private link to the YouTube. So if you want to share this out with any folks, and if you'd like a copy of the PDF version of the deck from today's presentation, just send us an email to info@revenuehealthsystems.com, and we'll get that right out to you. But thanks again to everybody who listened in, and we really do appreciate your time. And for now, that concludes our webinar. Look out in the future, we'll be putting more on in the coming months. Thank you very much.